بسم الله الرحمن الرحيم والصلاة والسلام على رسولنا الكريم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. السلام عليكم ورحمة الله وبركاته. My name is Dr. Adla Albabtain, Consultant Obstetric Gynecology in MOH, Deputy Head of National Training Project Technical Affair. Hello everybody and welcome to the 7th webinar organized by NTP on COVID-19 management. MOH actually is quite keen to provide topics which help its staff during this pandemic to update their knowledge and keep them well informed. Today, our webinar title is Diabetes in COVID-19. Many queries actually appear and need an answer from the diabetologist. These queries are: is there any increase in the risk of infection with COVID-19 in diabetic patients? Is there any increase in the risk of complication in those diabetic patients who got already the infection of COVID-19? And actually, do we need to change the medication during this pandemic for the diabetic patients? And also, can the diabetic patient monitor their blood sugar at home during this era? And if consistently high blood sugar, what to do? They are afraid to go to the emergency room. The number of the OPD reduced dramatically. So what to do? All these queries are going to be answered by this webinar. Our speakers today are Dr. Waleed Aldhahi. He is consultant endocrine diabetes and metabolism, and he is president of Kuwait Diabetic Society. He is head of diabetic division, Mubarak Al-Kabir Hospital. And the other speaker is Dr. Thamer Aleissa. He is consultant endocrine diabetes and metabolism, and he is head of division endocrine diabetes and metabolism in Jabir Al-Ahmad Hospital. Now I leave the floor to Dr. Waleed Aldhahi. Thank you.
Good evening, everybody. Today I'm talking about diabetes with COVID-19, a very hot topic nowadays. And as you know, diabetes is one of the major diseases that affects our population. My name is Dr. Waleed Aldhahi. I am the consultant endocrine and diabetes and head of diabetes unit in Mubarak Al-Kabir Hospital. So what we know about diabetes and COVID-19 has been changing over the last few months. Every minute there is new research come that actually tell us more information about the relationship between the two diseases. As we know, the background with severe COVID-19 disease has been related to many cardiovascular and metabolic problems, mainly arterial hypertension, dyslipidemia, visceral obesity, and fatty liver. And you know that this constitutes the main metabolic abnormality that happens with what we call dysglycemia and diabetes. Now, there is association between diabetes and actual viral pandemics in the past, and we learned from the past a lot. For example, HbA1c more than 9% have been linked to 60% increase in risk of hospitalization in pneumonia and severity during bacterial infections. In 2002 and 3 outbreaks, the diabetes considered as an independent, when you take all the variables as a complication of for complication and death. For H1N1 infection in 2009, there is 3 times risk of hospitalization if you are diabetic, and 4 times risk of ICU admission if you are diabetic. In the 2012 MERS-CoV infection, 50% of the population were diabetic, and as you know, it happens mainly started in Saudi Arabia, and lots of diabetics were involved in this disease. The odds ratio for severe critical MERS-CoV-1 range between 7.2 to 15.7. So this is a very significant rate, and the mortality rate was up to 35% in diabetic patients in the MERS-CoV-1. So there are lots of historic background telling us how much diabetes is important cases of this pandemic. So the prevalence of diabetes and hypertension and other comorbidities in COVID-19, and these are several studies throughout the world. You can see here, this is from China, and then later came down from USA and from Italy, and you can see the number to the population and to the population studied. In Italy here, you can see that up to 33.9%. So it depends on where you study the prevalence rate of diabetes, and compared to hypertension and cardiovascular disease is still high in patients with COVID-19. Now, there are lots of pathophysiological changes that have been related to diabetes and COVID infection. And we know from previous studies that SARS-CoV-1 infection has caused hyperglycemia that was persistent for 3 years after the recovery of SARS. And now we know that there is ACE2 receptor found in the pancreas. So the virus has been also identified by many autopsies that was really reaching the pancreas. And when it reached the pancreas, it actually basically causing inflammation, and that inflammation lead to either worsening of diabetes or new onset diabetes. Now, when we talk about the issue of diabetes, hypertension, metabolic syndrome, the renin-angiotensin-aldosterone system inhibitors in patients with COV-2 came to the question very early in the pandemic, and people was relating the ACE2, which is actually a receptor for the SARS-CoV-2, and the inflammation and the effect of the using of drugs that may affect angiotensin. So ACE2 was found in the, as you said, pancreatic beta cells, adipose tissue, small intestine, kidneys, and diabetics. We know that diabetics, they have upregulation of ACE2. And is that really the case? Why diabetic, they have problem? This is one of the questions. Now we know when you use ACE inhibitor and ARB, you're inhibiting the formation of angiotensin 2, and this may lead to upregulation of ACE2. So it was thought that using of these medications may be harmful in patients with hypertension and diabetes, but actually this was later changed because they found that there is no evidence that supports. On the other hand, actually when you use ACE and ARBs, you increase the angiotensin 1 to 7, which is more friendly to the vessels, comparing to angiotensin 2, which is causing acute lung injury and lots of bad things. So what do we know about ACE2? Treatment with ACE inhibitors and ARB has been a potential to cause upregulation of ACE2, as we said. Mice with coronavirus-induced lung injury showed improvement when they are treated with angiotensin receptor blocker, losartan, in this study. So this disputed the idea of actually having these drugs may be harmful. So most of the general bodies like ADA, American Heart Association, actually advise the patient to continue to take this medication. In one retrospective analysis of 112 COVID-19 hospitalized patients with cardiovascular disease in Wuhan, there was no significant difference in the proportion of ACE1 and ARB medication between survivals and not survivals. So this close up the story of ACE2 and take it out of the picture. Now, DPP4, as you know, also is part of diabetes, and we have DPP4 inhibitors, and this was also a question that came, that does really DPP4, which is a type 2 transmembrane glycoprotein that's been associated with viruses, does really this lead to a problem? Now, the use of DPP4 inhibitors may reduce the inflammation when you actually look at the studies, but this is all theoretical. So although this is just to tell us that it's safe to use DPP4 inhibitors in any patient who's having diabetes. We don't stop them because of the theoretical issues, but it may be helpful. There are lots of studies looking at this, that it may be actually more beneficial to the patient rather than harmful. And there are many studies going on regarding this. So the risk of severe COVID-19 and diabetes, why diabetic have increased risk of COVID-19 severe infection. So we know that in diabetic, the primary risk for severe pneumonia is there. It's around threefold high mortality rates in diabetes. 20% of all cases of severe pneumonia occur in patients with diabetes. Diabetes is a major contributor to MERS-CoV. As we said, risk of fatal outcome of COVID-19 is up to 15% higher in patients with diabetes. So the diabetic will not have increased rate of catching the disease because that's the same as anybody else catching the disease. But when they have the disease, we know it's become more severe, and there are many reasons for that. So there are lots of comorbidities that may actually explain to us why we have increased risk of severe infection. Obesity, heart and kidney disease, uncontrolled diabetes, inhibition of neutrophil chemotaxis, altered cytokine production, phagocytic infection dysfunction, phagocytic cell dysfunction that happens with diabetics, impaired T cell mediated immune response, and ineffective microbial clearance. And that was also seen that diabetics take longer time to clear their virus, or they have longer viremia compared to non-diabetics. So these are the reasons why they have risk. Now, there are lots of studies looked into this, and I just summarized some of the important things. Increased ACE2 expression that was really seen in mice in diabetics. Increased furin, and furin is one of the important factors in inflammation. So diabetic associated with increase in this furin, which is the type 1 membrane bound protease belonging to a protein convertase BCSK. It's involved in the entry of coronavirus into the cells, and increased furin may be reported in diabetic, and this may facilitate viral replication. Impaired T cell function, as we said, increased interleukin 6, which is one of the, have lots of deleterious effects, especially in the cytokine storm. So there are lots of changes that may make the patient, the diabetic patient, having more risk. Now, when you look at presentation with SARS-CoV-2 infection in diabetics, they have less fever, 58, 59 compared to non-diabetic, less chills. As usual, diabetics don't present with a typical symptoms. As we know from previous other risk factors like cardiovascular disease, patients or diabetes don't present with typical chest pain. The same thing, they have less fever, less chills, less chest tightness, and less shortness of breath. And that may lead that the patient will come later to you in the hospital, and that's why they present with a very bad disease, and this is one of the reasons. Sorry. So patients with diabetes, as we said, they remain infectious for longer period than people without diabetes. And there is possibility that reduced viral clearance in these diabetics have been, seen, especially in patients who are also using steroids. So there are lots of observations about this kind of thing. So the fatality rate overall, if you look at patients with who die from COVID-19 infection, the fatality rate is over 2.3%. People with cardiovascular disease around 10%, diabetes 7%, and hypertension 6%. So if you imagine your patient, you will never find diabetic without hypertension or ischemic heart disease. So when you put these all together, probably the risk is going to be exponentially very high. And this is, you can see from different studies from China, from CDC, from Italy, you can see that once you have diabetes, you have very severe infection comparing to non-diabetic. So this is having diabetes make your infection more severe according to most of the studies. So prevalence of survivals versus non-survivals in patients with COVID-19 with diabetes. And you can see here, the dark is survival and the gray is non-survival. So with diabetes, you have more non-survivals comparing to others. Now, new onset diabetes, and there is lots of observation that been seen around the world. And also we saw it in Kuwait that there is new onset diabetes in case of severe metabolic complication in patients with COVID-19. Some of them, they have pre-existing diabetes. Some of them, they develop ketoacidosis, hyperosmolar. So all of this is still under actually follow-up. There is a registry, international registry is open for actually collection of cases. Still, we're learning about why some patients develop diabetes while they have no diabetes before COVID-19. And this is paper from a correspondent from the New England Journal encouraging this kind of registry to look for new onset diabetes and COVID-19. So when we look at COVID-19 and diabetes, we're looking at, bidirectional relationship. So diabetes increase the risk of COVID-19, and COVID-19 may be associated with new onset diabetes, increase the risk of diabetes, ketoacidosis, and hyperosmolarity in patients who already have diabetes, and they need exponentially high dose of insulin when they are admitted with uncontrolled diabetes. So we are looking at two diseases that actually feed each other, and it's very bad when they come together overall. So this is the introduction for just the diabetes and COVID-19. Now, the management of diabetes with COVID-19, as you know, has been also changing. There are some evidence that some medications is good, and there are some medications that have been implicated that we can use them or don't use them. But this is just a summary of what's happening, and I choose some of the guidelines that we go through for it. So optimal glycemic control, premature discontinuation of therapy, it's very important. So many patients think that, I may stop my medication and this, I'm staying at home, let's change my medication. That's actually the contrary. You need to keep your medications. You need to actually have optimal control, because once you get COVID-19, your rate of infection, your severity of infection is going to be very high. Frequency of monitoring is important, and stabilizing of cardiac and renal status. This is very, very important. We encourage our patients to keep their antihypertensive, especially antihypertensive. Don't stop your antihypertensive. Follow up your blood pressure, because uncontrolled blood pressure, angina, all of these things, don't stop your aspirin. All of these things are also very important. Immunity, you can boost the immunity of your patients by doing, vaccinations for pneumonia and influenza, and also this is for diabetics, should be regularly. Use of vitamin C, D, B, zinc, quercetin, which is, a sort of berries products, and melatonin has been implicated without big evidence, although, for example, for vitamin C, D, B, and zinc, there are some evidence that actually it may help the patients to be regular on these supplements. Poor nutrition is also important. Nowadays, people are staying at home most of the time. They are cooking a lot, lots of carbs, and this is also have to be informed to our patients. Regular exercise is important, because that's boost immunity, and also it's good for the diabetes in general. So patients who need special attention when we talk about diabetes, and these are slides from Joslin Diabetes Center, one of my colleagues there, they gave it to me. Elderly more than 60 years old. So especially elderly and diabetes, they have to be very cautious. Type 1 diabetes with a very high HbA1c, anybody with cardiovascular disease and diabetes, fatty liver, obesity, which is, very big BMIs, more than 38 to 40, islet or pancreatic transplant. So any transplant by itself is a very high risk. If you have diabetes, again, it's even higher risk, and chronic kidney disease is also one of the high risks. The therapeutic aims is for a blood sugar between 4 and 7, as usual, postprandial, less than 10 according to the ADA, less than 9 according to the Europeans, HbA1c less than 7, 6.5 to 7 according to your patient age and situation, and continuous glucose monitoring should be, if the patient is using, 70% of the time should be within the target, and hypoglycemia less than 4%. And we know that there are many of our patients now use lots of continuous glucose monitoring, like freestyle Libre, or patients on the pump with the sensor. So these patients have to have more than 70% of their readings within the target range. So at home, use contact with treating physicians. Now, there are lots of ways to reach physicians. We encourage the doctors to give their patient options to reach them if they don't have to come out of home. Maintain hydration is important. Let's remember that using acetaminophen may alter the CGM results if they are used regularly throughout the day. Insulin dose may need to be increased if the patient is actually having any stress or fever or any situation where the sugar is going up. And change of oral medication should be considered in these patients, and they don't stick to one regimen all the time. So this is practical recommendations in the management of diabetes in patients with COVID-19, published in April 23rd here. And basically, they looked at the use of metformin, and you can have increased chance of dehydration and lactic acidosis when you have COVID infection. So when you have COVID infection, you have to consider discontinue metformin, although just a week ago, there's a paper showed that metformin may actually reduce the inflammation that's happening with COVID infection. But if this patient is sick and he is dehydrated, probably as a general rule, we don't use metformin, and we have to monitor renal function. SGLT2 inhibitor, again, when there's somebody who is in the hospital or admitted or having severe dehydration from COVID, you stop SGLT2 inhibitor and monitor the renal function, and that should be considered to be stopped. Sulfonylureas and DPP4 inhibitors, we don't have to have any specific changes except for sulfonylureas hypoglycemia. TZDs, because of risk of congestive heart failure, they should be continued if the patient have COVID-19 infection, especially patients who are in the hospital. If they are at home and maintained well, this may not be an issue. GLP-1 analog, again, risk of dehydration, adequate fluid, and regular meals needed for these sick patients, you may actually consider discontinuation of these medication. Insulin is the drug of choice for most of the cases. You have to monitor more with regular glucose monitoring, so you can actually follow up the patient as he having this infection. Now, this is the German Diabetes Association guidelines, and this is just a different view of looking across the sea to look how they say, and they have similar guideline, but with a little bit change differences. So recommendation for diabetic management in COVID-19 infections. So clinical practice recommendation: prevention of infection in people with pre-existing diabetes, need for optimization of control, HbA1c and blood pressure, as we said. Screen for manifestation of diabetes in patients who already having a COVID-19 infection. So anybody without diabetes and he have COVID, we have to screen him. As we said, these two diseases are bidirectional. And management of infected patient with diabetes should include, depending on severity of the COVID-19 disease, close monitoring of glucose, electrolyte, pH, anion gap, blood pressure, and HbA1c to make sure that the patient is not actually going into any kind of acidosis. Mild course disease, you keep the oral hypoglycemic agent, and this is we do also the same in Kuwait, even in the patient who is in-house. If they have very mild disease, just admitted, we just keep them on their oral. If no oral uptake, subcutaneous insulin is given. If the patient intensive care, we change them to IV insulin therapy. So patients who do not require intensive care, the ideal range is between 3.9 to 10. So this is 3.9 is the lower normal to 10, which is the highest acceptable postprandial. and trying to avoid hypoglycemia, which is by definition is below 3.9. Although in the hospital, we like the sugar to be a little bit higher than 3.9. HbA1c target less than 7.5. As you can see here, it's a little bit laxer than the Americans. And if the patient in the intensive care, you blood sugar between 7.8 to 10, blood pressure 135/85, as we usually do in our daily practice. So this is again the continuous of the German recommendation. If insulin treatment is the first choice of patients who are having severe infection, for non-critical patients, subcutaneous for critical patients, you go with these IV insulin overall. Metformin, stop if the fever is more than 38 or patient have respiratory failure or renal failure. Resume if he is free out of fever, adequate fluid intake, eGFR more than 30, and the patient have exclusion of hypoxemia. So if the patient start doing well, metformin should be stoned down, and this is basically applicable to our daily practice. SGL2, again, the same as the American, you stop if there's fever because of the fluid intake and risk of metabolic abnormalities, and resume if he is fever-free, if there's adequate oral fluid intake, if his eGFR is okay, and well-adjusted acid-alkaline balance is also there, his fluid balance is okay. DPP-4 inhibitors can be, continued as soon as the patient can take oral. Pioglitazone should be stopped, as the reason is because of the CHF, as we said. GLP-1 can be continued, maybe stopped if the patient having more favorable insulin, that the patient is becoming more sick and you don't want the patient to have more vomiting or more GI side effect. Here, statins continue of treatment while monitoring CK level and serum, especially in severe cases. If the CK levels increase during COVID disease, you may stop statin. So this is basically what the German guidelines telling us for the management of COVID infections in the hospital. For intensive care, there are lots of general rules in the intensive care. Improve glycemic control, reduce glucose variability, which is important, reduce contact time for frequent glucose testing, and this is a very important issue. In the sick patients, also you don't want the staff to have all the time, be around the patient. Overcome glucose spikes caused by steroid therapy, because as you know, one of the standard treatment is giving oral or IV steroid for patients with COVID-19. Face the challenge of accurate testing by finger test and CGM because of the change in hemoglobin, because of use of acetaminophen. All of these may alter the results. And manage DKA if it happens in these patients. So this is glycemic variability, which is a strong independent predictor of mortality in critical patients. And you can see here, the more the variability, the more the hospital mortality. And we know from glucose variability that it's very difficult to actually check for glucose variability unless you use continuous glucose monitoring. And it's been standard in many big centers that they use continuous glucose monitoring in patients who are in the ICU. The reason is because you can deal with it with the better numbers. The second thing also, you can actually have the numbers from away from the patient. So the best option under normal scenario, IV insulin infusion overall. Avoid lots of glucose. Major limitations, increase contact time, 24-hour times per day for the staff. And this is one of the problem that the patient is having. This is basically in patients who are on tube feeding. To reduce glucose variability, you have to maintain the insulin infusion all the day, and we have some patients in the ICU that we follow, and we use IV insulin infusion continuously because of the continuity of the feed. If the feed actually is changing, then we change the infusion. If the feed stops sometimes, if he's not type 1, we also stop the infusion according to the feed. So this is an early observational and mitigation of challenges in diabetes management, COVID-19 and critical care units being given to me by our colleague and friend Osama from Jocelyn. And this is basically telling you the reduced glucose variability while in continuous enteral tube feeding in patients when you use basal insulin, NPH, or regular insulin Q6 hours. And see the numbers of hours you need to actually see the patient. So IV infusion, you have to be 24 hours, around the patient. And if you have basal bolus, 4 hours, NPH around 3 hours, and regular insulin around 4 hours. So four times, sorry. To use. IV infusion is the best in terms of glycemic control and the lowest in terms of variability. But you don't put everybody in infusion because you're going to expose the nurses and the staff that are taking care of the patient more times when you actually you go to the patient with COVID-19. So you have to also, when you do infusion, and we do that in Mubarak, for example, to relax the targets and not make it hourly, make it 2 to 4 hourly. Sometimes, if the patient for the first day is maintained with the same blood glucose, we make it 4 hourly, so we have less exposure to the patient. So the same thing, managing the insulin, you have to choose the best option for the patient, and also put in your mind that the staff don't have to be around the patient. Steroid therapy, mildly asymptomatic patient, they give hydrocortisone 400 BID. First day, then 200. This is their recommended protocol. Again, we can see cortisone is being used in diabetic patients who have COVID-19, and this may actually alter our insulin regimen that we use for our patient. So we always have a contact with our colleagues whenever they want to start, any steroids. We actually start to adjust the insulin accordingly, according to the protocol that has been used. Okay, factitious high blood glucose reading by finger stick. For example, if you give vitamin C, and this has been very adopted in the States, where they give big dose of vitamin, test plasma glucose at the same time of finger stick for 1 to 2 times, and see how much the differences. Because if you take the subcutaneous insulin at the same time, accurate, but if you have it with how much is going to use the number. So advantage of continuous glucose monitoring: reduce contact frequency, monitor glucose variability on IV insulin, causes of interference, hypoglycemia, acetaminophen, and other drugs like albuterol can also affect the use of CGM in these patients. So we have to be cautious in interpreting the glucose value. Also, again, the excursions difference in terms of when you use these medications, and the effect on the CGM is also have to be put in mind. Again, DKA in unexperienced words, we have many DKAs run by non-diabetic, and we have been helping our COVID teams in terms of over the phone. COVID-19, they developed DKA, and here just telling you the idea of giving a simpler form of protocol that you can the patient. Also, once the patient get out of acidosis, quickly you have to shift him to subcutaneous to lessen the exposure of the staff to the patient unnecessarily. Insulin pump and another hybrid closed loop, which we don't have in Kuwait, but we do have the insulin pump. When the patient develops COVID-19 and he is well, not in the ICU setting, we keep him on the insulin and keep him on the same doses. Maybe we increase the basal and boluses according to his blood sugar, but we usually keep it because it's easier for the patient to stay on it, and also how to deal with insulin pump, so you don't have the exposure of staff of giving insulin all the time. So in conclusion, diabetes is a risk factor for hospitalization and mortality COVID-19. In diabetic, well managed, the risk of getting severe sick is about the same as the general population. So control of diabetes is important. We don't know any reason COVID-19 will pose a different risk of type 1 and type 2 diabetes. We still have no evidence for that. People with diabetes, or those with above their cardiac disease, uncontrolled hypertension, high cholesterol, smokers, CKD, dialysis, obesity above 40. These are the most high-risk diabetic that may develop severe COVID-19. Thank you very much.
Assalamu alaikum. Good evening, everybody. My name is Dr. Thamer Aleissa. I'm a consultant endocrinologist, diabetologist, and head of division of Jabir Ahmed Hospital and the clinical staff at Desmond Diabetes Institute. I would like to talk to you today about inpatient management for patients who admitted with COVID-19. Now, I'm sure you had some information previously about diabetes and COVID in general. I'm going to mention some of these items, then move on to the management part. So these are the objectives for today. Of course, everybody's aware how the cumulative cases of COVID infections is increasing. Maybe we're facing more a new challenge in the last few days with much increased cases. Kuwait is not an exception for that, and we've also seen increased levels of cases related to COVID-19 infections. First important thing we have to understand and realize that high prevalence of diabetes makes it an important comorbidity in patients with COVID-19. And also, because of diabetes is a chronic condition, that's one of the challenges that we face when people get infected with COVID-19. One of the earliest trials that came out and papers came out and described the prevalence of comorbidities. These are from Chinese paper with 46,000 individuals involved, showing that diabetes has high prevalence as a comorbidity compared to in the patients who got admitted with COVID infections. Their prevalence in this group of patients is about 8%, but that's low because of the population in China. Is actually the prevalence of diabetes is much lower than what we see here in the Gulf region or in the North America. So it corresponds basically to the prevalence that they see in their population. This trial did not show, the study did not show increase severe severe diseases or severe complication related to non-severe in patients who have diabetes. But there are other papers who showed the opposite also. Early in March, also the CDC has put on that people with diabetes are at high risk of severe illness, and these patients need to watch out for not developing this infection. One of the papers that came out describing, talking specifically about diabetes and COVID infection was the Curando trial. It was done in Italy. It was done in France. And they included about 1,300 patients who were diabetics, and they were hospitalized. And then they looked at the patient who had related or developed to death, and some of them had other comorbidity or complications related to their COVID infection. What they saw is that the majority of these patients were male, so about 65%. Their mean age was 70, these diabetics. Their A1C was 8.1, so they are basically uncontrolled, older male patients who developed or they require the hospitalization for COVID infection. They also, about 40% to 45%, they had some sort of micro or macrovascular complications, and about 40% were on insulin therapy. After a follow-up for 7 days since the admission, about 10.6% had the prevalence of death among these patients. And then the primary outcome, which was death or mechanical ventilation on day 7, about 30% of them had developed this outcome. What it seems like factors can independently associated with death in these diabetic patients, where if they had microvascular complication or microvascular complication, if they had obstructive sleep apnea, the age, the dyspnea, the GFR level, the AST, platelets count, and C-reactive protein. So these ones that predicted the death for these patients. For death or mechanical ventilation, also BMI was a very important factor in these diabetics. So the higher the BMI, the higher the risk that they will go into a mechanical ventilation. Also, lymphocyte count, the lower the lymphocyte count, also put them at risk of developing these kind of complications. The first trial, the first paper that came out actually from Kuwait, talking about the clinical characteristics and mortality related to the COVID-19 infection in the ICU setting in Kuwait. So it was for about 103 patients that were admitted at the ICU at the Jabir Al Ahmed Hospital between 1st of March and the 30th of April. There was 103 ICU patients. Diabetes was the most common comorbidity in these patients. About 40% of them had diabetes, followed by hypertension. And the higher proportion of disease patients were hypertensive compared to the discharge group who were able to get discharged. Diabetes did not reach a statistical significance in that part. And disease patients with diabetes were not statistically higher also in proportion compared to the discharge group. Maybe it's required more time or even more patients to look into that, because there were some patients or some trials who looked at the risk of death, and there was higher in patients who have diabetes. The severity of the disease, also there are several papers that came out describing the severity of the infection in COVID-19 and diabetes. This is a meta-analysis of about 6,000 patients, 6,400 patients, looking for composite of poor outcome, which was the relative risk was 2.38, and that included increased risk of mortality, severe COVID infection, ARDS, and disease progression. So all these composite outcome, diabetics have a higher risk of developing into these. What also been shown is that patients who were diabetics and had this poor outcome, there were several association with other issues related to these patients. So the age and the hypertension. So these diabetic, if they are older, and if they are hypertensive, then the risk of poor outcome is higher in these patients. Very similar to what we've seen previously with the French study. Do patients with uncontrolled diabetes do worse when they admitted with COVID-19? It seems yes. This is one paper that described the glycemic characteristics and clinical outcome of COVID patients hospitalized in the US. So what they saw is that with the uncontrolled hyperglycemia patient, they spend about 37.8% of their time with higher than the target blood glucose, which is more than 10. And these patients, when they had uncontrolled hyperglycemia, they had the longer median length of stay, 5.7 days versus 4.3. Also, in terms of mortality, patient also compared to the hyperglucose levels or uncontrolled hyperglycemia had a higher risk of mortality, 41.7%, compared to patients who are diabetic, but it seems like more better controlled when they got admitted. So uncontrolled diabetes could put the patient also at risk of developing poor outcome. This is another paper from China, looking for patients who also had a blood glucose that was not controlled, compared to and looking for their outcome. And what seems like patients who had poorly controlled diabetes, their survival was actually lower compared to patients with well-controlled diabetes. The hazard ratio was 0.114, so 0.14. So it was a significant result showing that. Also, patients from the same study, a Chinese study, looking for the poorly controlled versus the well-controlled diabetics. Poorly controlled had higher ARDS, had a higher risk of acute kidney disease, had a higher risk of acute heart disease, and also all-cause death. So it's very important to control the diabetes for these patients. Do patients with the newly discovered diabetes get less complications from COVID-19 than the patients with known diabetes? There's one paper that came out also from China, looking for patients who are newly diagnosed diabetic when they are admitted with COVID-19 versus patients with either no history of diabetes or had a hyperglycemia without diagnosis of diabetes, or had a normal glycemia. What it showed, these patients who had a newly diagnosed diabetes, so especially that these patients, usually when they are found to be newly diagnosed, they usually have a higher levels of glucose. So, so these patients did worse, unfortunately, in terms of mortality. So they had the highest mortality compared to patients who known to be diabetic or just hyperglycemic. The fasting plasma glucose corresponds very well to the increased risk of hazard ratio of mortality. You can see on the right side, somewhere between 7 to 8, where it actually makes a lot of difference in looking for the complications, specifically mortality in these patients. So fasting plasma glucose also very important here. Why do diabetics do worse, especially with the hyperglycemia? Well, because it seems like hyperglycemia can induce several physiological changes. It might affect the beta cell function. What causes hyperglycemia, I mean, in terms of COVID-19 infection, is that the COVID-19 infection could affect the beta cell, decreasing insulin secretion, and also with the cytokine storm, increasing insulin resistance. So these parts can increase the hyperglycemia. Also, hyperglycemia can affect the ACE2 glycosylation, which is the receptor that the COVID-19 attaches itself so it can enter the cell. So glycosylation of the for this receptor actually makes it easier for the infection to happen because these receptor needs a glycosylation, so the infection can enter the cells. So making them more obvious when hyperglycemia develops, then the infection might get worse after that. Hyperglycemia can also induce antitrophin 3, glycosylation, platelet activation, endothelial dysfunction, and all these can increase the risk of thrombosis and then multi-organ damage. What about the consensus now for management of COVID-19 and metabolic disease? So for patient in the ICU, inpatient or in ICU patients, we need to monitor for new onset of diabetes in infected patients. So anybody who walks into the hospital with COVID-19, we need to check his sugar level. Because if they are newly diagnosed, then that puts them at higher risk. If they are hyperglycemic with known diabetes or even without known diabetes, that also puts them at higher risk. Management of infected patients with diabetes ideally needs to be in an ICU, but we have to look into what's available and how is the patient condition in general. Plasma glucose monitoring, electrolyte, pH, blood ketones, or beta-hydroxybutyric acid. They are very important to monitor, especially with high levels of glucose. You need to make sure they're not spilling ketones that put them at risk for developing acidosis and ketoacidosis. Liberal use or indication for early intervention intravenous insulin therapy is important, especially in severe cases. And for exact titration is also important. And we try to avoid variable subcutaneous absorption because it might not be more a smoother control of diabetes unless we cannot do an intravenous infusion, then we can use the subcutaneous injections. What are the therapeutic aims for patients when they enter the hospital for diabetes control? Plasma glucose concentration would be somewhere between a 4 and an 8. This might be less enthusiastic physicians actually want to target that, and a lot of patients or physicians actually select a slightly higher target for these patients. These recommendation was put on a group of experts, mainly from North America. So they had slightly different choices for targets compared to Europeans. So they want the A1C to be less than 7%. And if patients depend on flash glucose monitoring or continuous glucose monitoring, then something we call time in range, which is how long the patients stay in the range, which is somewhere between 3.9 and 10. These patients need to be in the time in range of more than 70% of the day that they need to be in the range period. If they're frail or older patients, then more than 50% would be acceptable. Hypoglycemia, if it's less than 3.9, less than 4 in general, that could happen also in frail and older men, older people. And plasma concentration, as we mentioned, can be from 4, and maybe we can reach the level of 10, which would be the highest of normal. This is, again, different from the ADA standards for diabetes care that comes up every year, where they recommend that patients to have a target glucose somewhere between 7.8 and 10. It's recommended for majority of critically ill patients and non-critical patients. For more stringent goals between 7.1 and 6.1 and 7.8, this could be appropriate if you're able not to cause any much hypoglycemia. So you can see that there is a slightly different recommendation how to control it. But I think if you keep it somewhere between a 6 and a 10, that probably would be very sufficient in majority of patients. What about other management for other comorbidities that also develop with diabetes, especially hypertension and dyslipidemia? Antihypertensive need to be continued on, and also lipid lowering therapies need to be continued on. There are several advantages that could happen. With the antihypertensive, definitely need to have their blood pressure control. And there was an issue related to the ACE and the ARB use that they might have the ACE2 receptor that the virus binds to it more available. But this has been looked at a little bit more carefully in some of the papers, which show that actually it does not really increase the risk of worsening infection. So, and it might be even beneficial of keeping these therapies. Lipid therapy, probably there's an anti-inflammatory action, pleiotropic actions of the statins that probably would be helpful. Plus, patients, when they are developing such a huge stress with infection, they might increase the risk of developing myocardial injury. So statins will be a good choice to keep these patients on. Especially unless there's a contraindication for them, then it's better to continue these therapies. So the typical symptoms of COVID-19, which is the headache, the cough, the fever, the fatigue, the typical ones we know so far. And in diabetics, it might be slightly different in patients, even though they are generally the same symptoms, but they might be less common in patients with diabetes, especially fever. So they might deteriorate quickly, or they deteriorate to the point when they reach the hospital, they already had significant disease in their lungs, and they would require higher care or ICU care. We have to watch for diabetes emergencies, especially in DKA with type 1, and manage them aggressively and acutely as we can. Prognostic factor or markers in diabetic patients when they are admitted to COVID-19. There are when it was noticed or looked at diabetics when they enter the hospital, it seems like diabetics had a higher inflammatory response, higher C-reactive protein, ESR, interleukin-6, and also relative neutrophilia and lymphopenia. It seems like it was more in diabetics. Diabetics had a higher incidence of coagulopathy. They had a higher D-dimer, and they had more metabolic derangements, of course, the hyperglycemia, and also transaminitis. And they had severe pneumonia with higher radiological scores if you look at the infiltrate changes in the X-rays. When we start insulin therapy, and patients, when usually they admitted to the hospital, whether in the ward or in the ICU, it seems like the best action to do in these patients to control their diabetes would be insulin. So there are different ways of how we can start insulin in these patients. So if patients are eating, then we can start them on a basal insulin. Usually they're preferred in inpatient with glycine 100. We can start a dose of between 0.1 to 0.2 units per kilogram. You can select slightly higher. If patients are already on basal, then they want to try to match it as much as possible. Prandial insulin, rapid-acting analog would be preferred. You can do a 0.1 unit per kilogram per day in divided doses before the meals. And you can use correction insulin. You administer the correction also at the same time with the prandial dose together before the meal. And reduce the dose by 50% if it's given at bedtime. So usually we don't give a correction insulin at bedtime just because of the concern of hypoglycemia overnight, but you can give a correction if it's significantly high, and you can give half of the dose at bedtime. Patients who are NPO, then it's enough for them to keep them on a basal insulin with glycine 100. They don't need a prandial since they're not eating, so we don't expect spikes in the glucose control. If they are receiving parenteral nutrition, then it depends on, then also we place them on basal insulin, which we think is important. And we start insulin usually if the blood glucose is more than 10. And despite the use of insulin TBN in the solution, because usually when the TBN comes, they mix with the insulin in the solution, but we still can use basal insulin as a dose for these patients. For mixing it with the parenteral, we use a prandial. We actually use it as a prandial. So we use 1 unit for every 10 to 15 grams of carbohydrates in the parenteral solution. And that would mean like a prandial dose for these patients. And we can either rapid acting every 4 hours or a regular insulin every 6 hours because of the longer duration of the regular insulin. And you can use them as a correction as needed. If patient receiving continuous enteral nutrition, then again, we need to keep them on a basal. This is important. And you administer rapid acting insulin analog or regular insulin every 4 to 6 hours according to the duration of enteral nutrition. So so if it's shorter, if it's about less than 4 hours or about 4 hours, then you can use the rapid acting. If it's longer than 4 hours, then maybe you want to use regular insulin because of the longer duration of action. Patients receiving bolus enteral nutrition, you can give them only rapid acting or regular insulin without basal. And you can monitor how they can do if they're giving boluses of enteral nutrition. Some patients might require basal insulin, and it's not an issue, not a problem if you actually start them also on basal insulin. And for correction doses for patients receiving bolus enteral nutrition, you can administer them prior to the bolus and add them into the regular and into the prandial insulin dose. What about DKA? DKA been noticed with COVID-19 infection, whether in type 1 or even in type 2, because it can create significant deficiency in insulin and might cause this DKA also in these patients. The prevalence still is very low. This is one paper that came out describing about 660 hospitalized patients with confirmed COVID-19. Only about 6.4% presented with positive urine or serum ketones. Of them, only 3 patients actually met the criteria for DKA. But patients with ketosis, unfortunately, they had higher rates of ARDS. They required more mechanical ventilation. They had a longer duration of hospital stay, and even, unfortunately, higher mortality. So it's not very, very common, but if it happens, unfortunately, it predicts a worsening prognosis for these patients. What I see is a very good concise description or recommendation for diabetes patient management was from Diabetes UK. And they described how we can actually manage diabetics when they enter the hospital and how we can risk less mortality and risk related to the high glucose level. So patients, when they come in anyways, they have a high risk of hyperglycemia with ketosis. And the risk is higher if they are on SGL2 because they can induce DKA or euglycemic DKA. They cannot have atypical diabetes emergencies like mixed DKA and hyperosmotic states at the same time, especially with type 2s. Fluid requirements may differ in these patients, especially if they had evidence of lung leak or myocardial deficiency, for example, because of myocarditis or any cardiac injury. So you might be the fluids that you are required to give them because if they are DKA or HHS might be limited a little bit. Infusion pumps, we have them in very good numbers in Kuwait, but there's certain areas in the world. Here they talk about specific hospitals in the UK. They might run out of infusion pumps because they use them for other purposes like for sedations in ICU. Significant insulin resistance can be seen in patients with type 2 in ICU settings, and they need a higher titration of insulin. This is again continuation of the guidance. They call it front door guidance, which is basically start treating them from when they enter the hospital. So in people, COVID-19 infection in people with or without previously recognized diabetes increases the risk of the emergency states of hyperglycemia with ketosis or DKA or HHS or hyperosmolar hyperglycemic hyperglycemic states. This is a brief guidance on how to move on with these patients. So when patients present to the hospital or the emergency room, it's important to look when you do ABCD, which is basically the assessment that you do acutely in these patients, is that B could stand for blood glucose. And you need to also look at that as part of the screening. Now, shortness of breath also could be because of a metabolic acidosis. So they could be short of breath, not because of COVID-19 infection, but because of DKA. We have to ensure that all newly admitted patients are evaluated for diabetes, and we mentioned that it's very important. If patients have a glucose measurement, we have to do glucose measurements in all patients, and also ketones. If the glucose level was high, especially above 12 millimoles, then we have to look for ketones. We have to stop SGL2 in all types because they might increase the risk of dehydration in these patients, and we don't want to put them at risk for that. When this paper came in early April, they were talking about the safety of ACE inhibitors, ARB, and steroids because of the effect of the ACE receptor, but this is probably will be updated, or this risk probably will not be mentioned much more, since we think now it's very appropriate and safe to continue using ACE inhibitors. So blood glucose, we have to look at the level, and we have to know whether they're diabetic or not, but blood glucose by itself is an important thing to look at. And if they do have hypoglycemia less than 4, then we follow the protocol for fixing the hypoglycemia. If the glucose more than 12, equal or more than 12, or known to be diabetics, then we need to diagnose if they had DKA or not. That's very important. And if they had a hyperosmolar state or not. And here we have some of the, and they're basically the typical way of how to diagnose them based on having a normal or a history of diabetes or high glucose level with blood ketone positive or urine ketone positive, and acidosis based on a low pH or a bicarbonate to be less than 15. HHS defined as glucose more than 30, osmolality is to be high, more than 320, and pH more than 7.3. So no presentation, if patients develop a new presentation of diabetes, whether 1 or 2, we have to look for sepsis because it could be a source for this presentation. And so if it's COVID-19, we have to address that and treat it. And some patients who have type 1 or some of type 2s would depend completely on insulin. If they miss a few of the doses, that puts them at risk for developing DK. And so we have to make sure that's also important to look at. This is a recommendation for the blood ketone level advice. So if the ketone is less than 0.6, that's a safe level. So we can continue just basically monitor or manage this patient. The blood glucose, blood ketones between 1.5 to 2.9, that increases the risk of DKA. And so we have to give patients either oral or IV fluids. We need to consider rapid-acting insulin if glucose is above 16. Because 1 unit can typically lower glucose somewhere between 1 to 3. So this is how much you think you need to, and then you check the sugar after 2 hours. If the blood ketones is more than 3 or greater, then we have to check for the pH and bicarbonate to look for the acidosis. We can do that through the venous blood gas. And if DK is confirmed and high ketones is there, blood glucose more than 11, or a history of diabetes and the pH is low or bicarbonate low, then we have to initiate the protocol to treat their DKA. About insulin advice, always continue usual long-acting basal insulin. So if they're taking it at home, we need to continue that, very importantly. And patients who are very sick or not eating, they should have a variable rate intravenous insulin infusion. So if we can manage their diabetes based on insulin infusion, then it's important to do that also. And patient using a wearable diabetes technology. So if they're wearing insulin pump, then we can continue using the insulin pump if they are able to control it and manage it very well. If they're unconscious or they are very sick or being intubated, then it's better to not to continue the insulin pump and then try to treat them either with sub-Q or IV insulin. If they're using a continuous glucose monitoring, and there is a sufficient way of evaluating and keeping track on the values, so someone on the other end should be able to log in either electronically or have some way of looking at these values. So if that's possible, then it's okay to keep it. But if it's not possible to monitor these values, then maybe just depend on subcutaneous insulin. Subcutaneous or glucometer regular checks. So take-home points: possible increased risk of COVID-19 in diabetics with advanced age and comorbidities. Possible increased severity of COVID-19 infection in patients with diabetes. COVID-19 could have effect on pathophysiology of diabetes. That's why we see a lot of patients who present with diabetes with the COVID infection. And blood glucose is important for all patients who have diabetes and COVID-19 infection. And thank you so much for your attention.